Let's get started. Welcome. Hi, everyone. My name is Lisa. I'll be your MC today. This is our perspectives on atypical Parkinsonism, about multiple system atrophy and Lewy body dementia, with our movement disorder specialists and expert presenters, Dr. Catherine Longardner and Dr. David Coughlin. So a few things to note before we get started. So this is an annual series for us. We hold these on a monthly basis. Our next one and last one of the year will be the beginning of December. All of the sessions will be recorded and the recordings emailed to you and available online at our website. Any links or resources will be shared to you after via email. And we also have a post-session survey to hear some feedback from you about today's session. We will have times for questions. You'll need to use the Q&A feature, usually located at the bottom of your screen, to type in your questions, and we'll answer questions after each presentation. So with that, I will let Dr. Longardner take it away.
Okay, thank you, Lisa, and thank you everyone for joining. Okay, can everyone see my slides?
I think
Lisa,
so.
give me a thumbs up. Okay, thanks. All right, so I'm going to be talking about multiple system atrophy. These are my disclosures. I'm involved in a couple of clinical trials for MSA currently that's relevant to this talk. So these are the objectives for my 20-minute talk today. First, provide an overview of what is multiple system atrophy, identify some of the common motor and non-motor symptoms, discover how it's diagnosed based on clinical and imaging and other tests, discuss the symptomatic treatment options for MSA, and talk about how an interdisciplinary team can help in the care of MSA. And then last, I'll spend a couple minutes talking about current and upcoming research studies for MSA here at UC San Diego. So first, what is multiple system atrophy? This is a neurological condition that was first described in 1900 by French neurologists that's been called by multiple other names, including olivopontocerebellar atrophy, Shy-Drager syndrome, and striatonigral degeneration. Eventually, they settled on multiple system atrophy to describe the many systems involved in this condition. It is adult onset. It's sporadic, meaning that in most of the cases, there's not any genetic cause. It's chronic, meaning that it's a long-term condition, progressive, meaning that it does get worse over time. And it's quite rare compared to Parkinson's disease, for example. It's about 10 times more rare, with a prevalence of about 2 to 4 out of 100,000 persons, an incidence of about 3 in 100,000 people per year. And it's a neurological condition that causes, as I'll talk about, both movement and non-movement symptoms. And the hallmark feature is autonomic nervous system failure. So I'll just talk a little bit more about that before I go on. So what is the autonomic nervous system? This is the network throughout the brain, spinal cord, and the rest of the body that transmits information to control various bodily organs. It's sometimes referred to as the automatic part of the nervous system, because this is not under voluntary control. And this regulates things like breathing, heart rate, blood pressure, gastrointestinal function, bladder control. And typically we think about it in two major categories: the parasympathetic nervous system, or rest and digest, that is involved in those processes, and then the sympathetic nervous system, that sometimes we call fight or flight, and that is involved in other responses. So you can read through here, but the point is just to understand that multiple system atrophy affects all of these connections between the brain and all of the other organs, which is why it can cause so many different kinds of symptoms. Some of the symptoms from MSA could be speech or swallowing problems, excessive saliva, stridor or trouble breathing, changes in sweating, movement disorders such as incoordination, slowed or small movements, muscle stiffness, involuntary movements, changes in digestion, slowed gastric emptying, constipation, trouble with the bladder and sexual function, trouble with blood pressure control, changes in sleep, including REM behavior disorder, and changes in thinking and mood. And this is not a comprehensive list, but just some of the most common issues with MSA that can impact quality of life. What causes MSA? We don't know. In most of the cases, as I mentioned, it's sporadic, so not associated with any known genetic variants. We know that pathologically, we see this abnormal buildup of a misfolded protein called alpha-synuclein in the oligodendrocytes. Those are the support network cells in the brain and the nervous system. And then this abnormal protein that is misfolded induces other pathological misfolding in other nerve cells nearby and spreads. And there's no clear environmental risk factors for developing MSA. Some studies have shown that pesticides could be a risk factor, but it's not a strong evidence. Another study has shown that working as a machine operator had a higher risk of MSA. And as I mentioned, there's a few very rare genetic risk factors. There are two main types clinically of MSA, the MSA Parkinson subtype that usually presents more with muscle stiffness, slowness, and tremor earlier on, and then the cerebellar subtype that presents more with what we call ataxia, that's incoordination and imbalance early on. And then over time, these two subtypes kind of blend, and usually later on in the disease, most people will have symptoms of both types. And these affect different parts of the brain. Initially, at least the Parkinson subtype affects more the basal ganglia, and the cerebellar subtype affects mostly the cerebellum. So how do we diagnose MSA? As movement disorders neurologists, the sorts of things that we look for on the exam are changes in eye movements, changes in speech, problems with walking or balance, changes in coordination, movement speed, and then the muscle tone. We look for irregular movements that could be tremor, it's a rhythmic movement, or myoclonus, that's a brief irregular jerky movement, or dystonia, that is a twisting repetitive patterned posture, and increased reflexes. Just for example, these are the sorts of things that we're looking for on the physical exam. Other tests that can support MSA diagnosis would be orthostatic blood pressure measurements, so checking the blood pressure both lying down and standing up. That can be done on the bedside or at home, as well as with the specialized tilt table test. That is a special gurney where you're strapped into the bed, and it raises at different angles, and then measure the blood pressure continuously during that to look for a blood pressure drop. There's other tests, including thermoregulatory sweat tests and quantitative sudomotor axon reflex testing. These are done in special autonomic centers. We don't have this capability at UC San Diego, but there are other centers in the country that can offer these tests. And then blood tests for norepinephrine. Other tests that might be used include urodynamic studies. That's a bladder test where there's saline injected in the bladder and then measured after the bladder's emptied to see if the bladder's retaining urine abnormally. So those are some of the autonomic tests that can be done to support the diagnosis. And then a brain MRI can also be done that might show some specific signs suggesting MSA. And that includes the hot cross bun sign. This is part of the brainstem, the pons, and there's loss of the nerve cells there that makes this sign that looks like a hot cross bun. The putamenal rim sign, there's loss of the cells in the basal ganglia that causes this. And then another sign we look for is shrinking of the pons and the cerebellum. Other tests that might be used to diagnose MSA include nuclear medicine scans showing decreased signal in the basal ganglia and cerebellum compared to Parkinson's disease or other diseases. A cardiac nuclear medicine scan can also differentiate between multiple system atrophy and Parkinson's disease or dementia with Lewy bodies. This test should be normal in MSA most of the time, and then abnormal in Parkinson's disease and dementia with Lewy bodies. And then emerging biomarkers. These are used in clinical research and are starting to gain traction in clinical practice, at least the skin biopsy. This includes measuring levels of alpha-synuclein in the spinal fluid and in the skin. And Dr. Coughlin might talk more about that in his talk. So how does multiple system atrophy compare to Parkinson's disease? That's the most common Parkinsonian disorder, and there's a lot of overlap, especially early on, and it can sometimes be hard to distinguish these two conditions early on in the course of MSA. MSA presents usually a little bit earlier in the 50s or 60s, and Parkinson's disease usually presents in the 60s or older. MSA is a faster progressing disease compared to Parkinson's disease. The autonomic symptoms and multiple system atrophy are usually earlier and more severe compared to Parkinson's disease. Urinary retention is more common in multiple system atrophy compared to Parkinson's disease. In multiple system atrophy, people have more trouble with speech and swallowing earlier on. And usually if they have a Parkinsonism type of MSA, they don't have the same good response to levodopa, or sometimes they might not be able to even tolerate it because it makes their blood pressure much lower. And then the ataxia is unique to MSA and does not happen in Parkinson's disease. Usually folks with MSA will be falling earlier on within the first 3 years compared to Parkinson's disease that we wouldn't expect to see people falling that early. And then in MSA, cognitive and psychiatric symptoms are usually less common and less severe compared to Parkinson's disease. So next I'll talk about symptomatic treatment. Even though we don't yet have a cure for MSA, there are a lot of therapies that can help improve someone's quality of life, and I'll just spend a few minutes talking about those. The main thing here is that the symptoms, the treatment for the symptoms is personalized and depends on each individual's symptoms and priorities, and those might change over time as people live longer with the disease. The things that are more bothersome might change. And the important thing to keep in mind and to discuss with your doctors is that medications to treat some symptoms, such as the medicines we use for motor symptoms or bladder symptoms, might lower blood pressure. And also could worsen urinary retention and constipation. So just to keep in mind, weighing the pros and cons and balancing the side effects and the benefits of some of these medications, depending on which symptoms are the most bothersome. So just briefly, motor symptoms, that is stiffness, slowness, involuntary movements, dystonia, can be treated with carbidopa-levodopa in the case of Parkinsonism, and amantadine can sometimes also be helpful for the involuntary movements. There's not a medication that has been shown to be effective for the ataxia part of the motor symptoms. Physical therapy and occupational therapy are helpful for all kinds of MSA, and botulinum toxin injections can be helpful in the case of dystonia. For treatment of orthostatic hypotension, so this is low blood pressure on standing, the first step would be to look at the medication list and try to minimize any medicines that are contributing to low blood pressure. Drinking more water, the recommendation is at least 64 ounces or 2 liters a day. We recommend drinking that earlier in the day to prevent excessive urination during the nighttime. Wearing compressive garments such as thigh-high compression stockings and an abdominal binder can help improve blood flow back to the heart and reduce the low blood pressure when standing. And then lower body strength training can have the same effect by strengthening the leg muscles, helps improve the pump function of the legs to improve venous return to the heart. Adding salt to the diet can have the same benefit of increasing the blood pressure, and then raising the head of the bed at nighttime to 15 degrees ideally can help prevent excessive loss of water through the kidneys overnight. And then there are several oral medications that can be used for treatment of orthostatic hypotension, droxidopa and imidodrin, and then fludrocortisone and pyridostigmine are used off-label sometimes as well. For constipation, again, first reviewing the medication list and eliminating anything that's making constipation worse, drinking more water, exercising as much as you can, eating more dietary fiber, and then there are several oral medications, including prebiotics and probiotics that can be helpful for constipation management. There are also prescription medications that can be used, as well as over-the-counter medications. For treating the urinary symptoms, there are also oral medications that can help with this. Botulinum toxin injections in the bladder can help the bladder relax. Pelvic floor physical therapy can be helpful. Tibial nerve stimulator can help. And then sometimes catheterization is needed, and this could be done depending on the circumstances by a person themselves, and they might do it intermittently throughout the day, or they might have an indwelling Foley catheter that stays in the bladder. And then the catheter transmits the urine through a tube to an external source. And then stridor, this high-pitched breathing that sometimes can happen in MSA, can be treated with BiPAP or CPAP machine, or in severe cases, a tracheostomy. That's a tube that goes into the airway and keeps it open. So just briefly, I'll talk about the importance of a multidisciplinary care team for people with MSA. That's kind of the theme of our webinar today, and why that can be important. So MSA, as I've mentioned, is a multifaceted condition that affects many organ systems and different body parts, and it can be difficult to address all of these things in one visit with just one healthcare provider. And oftentimes you need a team of specialists that can adequately address all of these issues. And the other thing, as I mentioned, is that symptomatic treatment priorities might change over time. So maybe early on, the urinary symptoms are not so bothersome and can be adequately controlled with oral medications. But later on, someone might need to pursue some of these more invasive options, such as botulinum toxin injections in the bladder, or catheterization. And so that really involves a urologist, a specialist, to help manage that. And so just some examples of the role for different members of the care team. For speech and swallowing problems, a speech therapist can help. A neurologist could do botulinum toxin injections in the salivary glands to help reduce excessive saliva production. For stridor, a pulmonologist can be helpful. For the movement disorder symptoms, occupational and physical therapists and neurologists can help manage those symptoms. For constipation or delayed gastric emptying problems, a gastroenterologist can be helpful. For the urinary and sexual problems, urologists and pelvic floor physical therapy can help. For problems regulating the blood pressure, cardiologists or neurologists can help prescribe medications to raise the blood pressure. And then for sleep changes, sleep specialist. And then for thinking or mood changes, a psychiatrist or neurologist can be helpful at adding medications if needed. And then there's also a role for palliative care and social work just overall to help manage the complex and changing symptomatology. And then last, I'll talk for a few minutes. Let me just check the time. Okay, a couple minutes about research that we're doing here at UC San Diego related to MSA. I'll talk in more detail on the next slide about the first study that is an ultrasound blood pressure monitor, with the goal that we could use this in folks with MSA to monitor the blood pressure at home. And then just wanted to mention also a survey that is gathering information from people with MSA and other atypical Parkinsonian disorders to gather their perspectives on end-of-life health care and what are their priorities. We also have two biomarker studies that are investigator-initiated projects looking to detect misfolded proteins in skin and saliva samples in people with MSA and other types of Parkinsonism, with the goal that we can use these biomarkers to improve earlier detection of MSA and to differentiate it from other conditions that might appear similar clinically. So just briefly about the ultrasound blood pressure monitor, as folks with MSA know, the blood pressure can change very rapidly from very high to very low, and this can be difficult to monitor at home with a regular blood pressure cuff. And can lead to harmful consequences if not treated adequately, such as falls. And so we've been working for the past 5 years with Professor Sheng Xu at UCSD Department of Bioengineering to develop a device that uses wearable ultrasound technology to measure blood pressure continuously from arterial walls underneath the skin. And so the device is worn as a small patch over the artery, and we're currently working with them to validate this device. Other clinical research trials, so these are therapeutic trials related to MSA that are ongoing at UCSD. One is the Alterity study. This one is almost over, but I'll just mention it briefly. And then we have two other ones that will be recruiting. The Alterity study is a phase 2 multicentric randomized double-blind placebo-controlled trial for early-stage MSA, looking at an investigational oral medication that works to prevent it works to affect the way that iron is binding to ideally prevent abnormal buildup of the protein alpha-synuclein. And then this one, as I mentioned, is almost over. We had 3 people here at UCSD out of 77 around the world that enrolled, and the results are pending. Currently, we are recruiting for a clinical trial that's a phase 3 multi-center randomized placebo-controlled trial for a treatment of neurogenic orthostatic hypotension in MSA. So people that have symptoms from low blood pressure on standing. This is an oral medication taken once daily, and it's a long-acting norepinephrine reuptake inhibitor. This involves a 20-week treatment period, and then there's an option for a 2-year open label extension. And then starting soon, probably in the next couple of months, there's another disease-modifying investigational study, a phase 2 multi-center randomized double-blind placebo-controlled trial for MSA, looking at the effect of a novel small molecule oral medication that inhibits abnormal protein aggregation. So that one we anticipate will be starting in the next several months. And then just wanted to provide resources for folks with MSA. These are several websites that have a lot of good information and resources. And then I'll just stop there and allow a few minutes for questions. My email and contact information is here if you have any questions or feedback from the talk today, or if you're interested in any of the research studies that I mentioned, please email me and put you in touch with the research crew.
Awesome. Thank you so much for that presentation. If you have a question for Dr. Longardner, please enter that in the Q&A box at the bottom of your screen now. We do have one question for you. Does orthostatic tremor fall under MSA?
Oh, no, usually orthostatic tremor is not a part of MSA. There are other orthostatic movement disorders. Orthostatic myoclonus is more common in folks that have neurological conditions, but I'm not aware of any association between orthostatic tremor and MSA. Orthostatic just means it happens when you're standing up. So people with MSA have orthostatic hypotension, low blood pressure on standing, but usually not tremors.
Great. Any more questions before we move on? Aha, one more. Does a positive skin alpha-synuclein test equal either MSA or Parkinson's disease?
Oh, this is a good question. I don't know. Are you going to talk about this more in your talk, Dr. Coughlin?
A bit, but it's a
Okay.
very good question. I'm sure.
That's a good question. I think we don't know. I mean, we're moving towards, and the goal would be that we'd be able to distinguish the different types of alpha synuclein. So the type of alpha synuclein that is misfolded in MSA is different from the one in Parkinson's disease and dementia with Lewy bodies. Right now, I think that we can't really say that it's specific to one disease or the other, but eventually we hope to be able to say that. Do you have any comments
Yeah.
on that one, Dr. Coughlin?
It's a pretty rapidly moving field. For the longest time, we didn't have any way to identify alpha-synuclein protein in people while they were alive with any degree of specificity. Now there are two platforms that seem to work pretty well. There are definitely some nuances, and they're still pretty new, and we're learning about them. But yeah, one thing that we as a field have to grapple with a little bit is what is the significance of somebody who may have a positive alpha-synuclein biomarker, but who doesn't have stiffness, slowness, tremor, orthostatic hypotension, or any other disease feature anyway that would say maybe this person has Parkinson's or maybe this person has MSA. And that's one of the things that we don't know about yet anyway, whether somebody who has that type of biomarker signature might be at higher risk of developing problems in the future. And if they are, how increases that risk and when? So these are things that people are working on right now. But all medical testing really has to be done and should be done within the context of the person sitting in front of you. That's really the only way to get sensible results out of tests is to do them for people who are going to get the most information so that we can sort of change our thoughts and change our management of them anyway. So there may be something in the future where this is more useful for people who are asymptomatic, and we're not ignoring that. That's an active area of research right now anyway. But there's still like a lot of stuff that we still have to figure out as a scientific community anyway.
Great, thank you. One more question. Is there a chance that Parkinson's gets misdiagnosed as Alzheimer's disease?
Hmm. So Parkinson's disease is usually a clinical diagnosis, and there's certain things we look for on the exam that we use to diagnose Parkinson's disease. So I guess it's possible to be misdiagnosed, but oftentimes people with Parkinson's disease can have some thinking and memory problems, and sometimes people with Alzheimer's disease could have some motor symptoms or Parkinsonism. So I think clinically and using neuroimaging, there should be ways to distinguish them, but there can be overlap, and some people with Parkinson's disease might have cognitive impairment that could be mistaken for maybe Alzheimer's disease, or people with Alzheimer's disease can sometimes have breast tremor or slowness or stiffness that could look like Parkinson's disease, and people can have more than one thing.
Okay, great. Now with that, I think we'll move on to the next talk. Dr. Coughlin will share more about Lewy body dementia.
All right. I think you guys can see slides now.
Yep.
Thanks for the invite. Happy to talk about some of these things. And I'm going to focus on Lewy body dementias and some of their clinical manifestations and treatment options, and a little bit about biomarker and research things that are happening right now in that field. I don't have any financial disclosures that are relevant to this talk. I do receive research funding from the NIH and a couple of places there, and I used to have a grant from the American Academy of Neurology. So to talk about Lewy body dementia anyway, I think we first have to talk about sort of where it fits in with our thought processes. Like dementia in general is a very non-specific sort of umbrella term, and really just meant to describe people who have problems with memory or thinking that's significant enough that it impacts their day-to-day functioning. And there's a lot of different things that can cause dementia. We think that by far the most common is Alzheimer's disease anyway, and then questionably vascular dementia, which happens because of very small strokes and vascular changes that happens as people get older. But number 3 is Lewy body dementia on this. And I've heard other people, and I think I agree with this, we talk about Lewy body dementia as if it's the most common type of dementia you probably haven't heard of anyway. Now, depending on what you're reading, sometimes people use these terms a little bit interchangeably, but I think that this is probably the way that most of us try to think about it. There's really 2 big types of Lewy body dementia. There is the entity dementia with Lewy bodies, and then there's Parkinson's disease dementia. So in the case of Parkinson's disease dementia, people usually have stiffness, slowness, tremor, Parkinson's disease, and they have those movement changes first, and they usually have pretty normal cognition at the beginning, and that persists for many, many years anyway, and the memory problems only come after a protracted period of time. As opposed to dementia with Lewy bodies, where the memory problems seem to either come first or they go along basically at the same time with the movement problems anyway. Now, despite this, there's a whole lot of overlap in the features of these, as in like the cognitive changes that happen with Parkinson's disease dementia and dementia with Lewy bodies are very similar to each other. Both of them certainly share the stiffness, slowness, tremor signs that are indicative of Parkinsonism. And most people will have visual hallucinations, constipation issues, loss of smell, and acting out their dreams that we call REM sleep behavior disorder. So there's a lot that's in common. And truthfully, they also have a common neuropathology in the vast majority of cases where they see these little clumps of misfolded alpha-synuclein protein, which has earned them sort of this umbrella term encompassing both, called Lewy body dementia, named after these little findings. I'm going to talk mostly about dementia with Lewy bodies, but a lot of what I'm going to say, especially for this middle part of the Venn diagram, will apply to both anyway, so we can talk a little bit more about that as we go. But as far as like basic dementia with Lewy bodies epidemiology, we think it's somewhere around 10, maybe a little bit higher percent of all dementias. It probably affects close to 1.5 million people in this country alone. We have an imperfect understanding of how many people have this, and some of the studies have estimated somewhere between half and 30 people per 100,000 in this country anyway. Certainly, the likelihood of getting dementia with Lewy bodies increases with age, with the large majority of cases having their onset over age of 70. There are young onset cases that what we would call young onset when people start having symptoms less than age 65 or so, but they're much more rare. It's probably about 2 in 100,000 people, or maybe even less than that. I will say that probably dementia with Lewy bodies is underdiagnosed overall. And if there is something that it's going to be missed or called, somebody's going to misdiagnose and call it something else, it's usually Alzheimer's disease, frankly. Now, the wide variability in some of these numbers is largely because we've changed a little bit of our diagnostic criteria, and some of the sort of knowledge about Lewy body, dementia with Lewy bodies has changed over time. So more people are starting to know about it and recognize it in the clinic. But I want to talk a little bit about some of the clinical features. I mean, to have a diagnosis of dementia with Lewy bodies, you have to have dementia. And I mentioned this, but it involves a progressive and substantial decline in memory and thinking. And then these other core features as well, where there's fluctuating cognition, visual hallucinations, some degree of Parkinsonism, and then the sleep problem, REM sleep behavior disorder. So the specific memory problems that tend to happen in DLB, and these are, again, similar types of memory problems that tend to happen in Parkinson's disease dementia, is mostly people have problems with attention, where maybe if they get interrupted, they'll have a lot of difficulty coming back to their thought, or they might lose themselves in the middle of a sentence. Executive functioning like planning and multitasking is often affected early. And a little bit later is often visual spatial function, as in might have trouble like getting around your neighborhood. Some of the ways that we test this in the clinic is asking people to do some of these visual spatial functions, like copy a complex figure or judge the orientation of certain lines anyway. Compare and contrast, short-term memory stuff is usually less affected, I would say. It's not that it can't be affected, it's just that it's a little bit less affected. As in, most people with DLB have less problems with repeating questions, asking, what are we doing today? What appointment are we going to? Where are we? It's a little bit less common that they have problems like that. There's also cognitive fluctuations, which are a core feature of dementia with Lewy bodies, and these are spontaneous alterations in attention and arousal. And this can be pretty startling. Periods, a long time of people looking pretty good, being pretty close to normal, and then periods that can last minutes or hours where they're intensely confused and even sleepy and hard to arouse. People may stare off into space for long periods of time, and this can be very, very alarming to caregivers and usually prompts a couple of emergency room visits anyway. And they get worked up for strokes or seizures. They don't find anything in the ER. And we're learning a little bit more about why this happens, but we actually think it has to do with brain changes that are very, very deep in the brainstem that actually have to do with the sleep-wake cycle. And namely that this system that usually keeps us awake is kind of turning off periodically and causing this sort of like kind of shutdown of the entire system anyway for a few minutes or maybe a couple hours. Another thing that most people have is going to be visual hallucinations. These tend to be well-formed and come out of nowhere, at least in their sort of later stages. They tend to be small things like insects, animals, children, other people anyway. There are sort of less severe versions, I think I would call them, where people maybe feel like there's something on the edge of their vision and they turn around and look and there's nothing there, or illusions that arise from other stimuli. For example, like a curtain, it looks like there's a person in the curtain, or there's a face in the clouds or in the tree. These are pretty common, to be honest. They're present in probably at least 80% of people who have dementia with Lewy bodies as well. So that's one of the other core features. And then there's Parkinsonism, something that we work through with the clinic all the time. It's at least some feature of stiffness that we can feel on exam, slowness in some of the movements that we'll do as part of our physical, and resting tremor is a big part of it too. The Parkinsonism in in dementia with Lewy body specifically tends to be less levodopa responsive than traditional Parkinson's disease anyway. We might try it in certain circumstances anyway, but people with DLB tend not to respond as robustly overall. But there's a lot of other things that can happen in DLB, and for people who maybe are caregivers of people with Parkinson's, they'll recognize a lot of overlap with Parkinson's disease as well. So most people have lost their sense of smell. There's a lot of issues with balance. They too can have orthostatic hypotension and lightheadedness on standing. Constipation is common and sometimes quite severe. There may be hallucinations in other modalities, although they're much less common, like hearing things that aren't necessarily there. Delusions and paranoia are also pretty common, believing that they're being poisoned, or a spouse is unfaithful, or people are trying to break into the house, unfortunately, are fairly common and very difficult to manage. Anxiety and depression and apathy are also other mood-related changes that do play a significant role in many people who have dementia with Lewy bodies as well. So for somebody who is coming to the office anyway, the primary thing that we're going to do anyway to try to diagnose one of these conditions is still going to be take a history and do a physical exam. Absolutely. That's going to get you most of the way there in the majority of the cases. But we do have some other tools that are available now that can help us a bit. And these are a handful of imaging type studies that can help for certain cases where it's appropriate to do so. DAT scans, which has been around for close to 20 years at this point anyway, is a very well-validated tool to show dopaminergic cell loss in Parkinson's disease, but there's also problems in DLB too, where they have less dopamine uptake. This is a DAT scan. I'm sorry, I gotta fix the numbers here. I will say that DAT scans are not perfect. There's probably about 10% maybe of people with DLB who have normal DAT scans. We're still trying to figure out if that's accurate and what that means. MRIs can be helpful a little bit when trying to differentiate DLB from Alzheimer's disease. Mostly we're looking for areas that are primarily affected by Alzheimer's disease and hopefully seeing that they're pretty normal in a patient with DLB anyway. This is an example of an MRI. This is a person who has Alzheimer's disease, and these parts that are in the little red box are the area of the brain called the hippocampus, which is primarily involved in governing short-term memory and encoding. And it's pretty shrunk in the person with Alzheimer's disease, and it's pretty full in the person with dementia with Lewy bodies. FDG PET is something that my cognitive colleagues order a fair amount, and basically measuring glucose metabolism in the brain anyway. And there are some patterns that are more or less consistent with Alzheimer's and more or less consistent with DLB. And lastly, there's a heart study actually, because things like DLB and Parkinson's actually affect how the nerves hook up to the heart. You can actually see that those nerves are not hooking up in cases of DLB and PDD using this kind of advanced cardiac imaging that we can get here in a handful of other places around the country too. This is maybe we'll end up talking a little bit more in depth about this, but one of the things that's come along in the last couple of years actually is a fairly significant advancements in ways to detect that alpha-synuclein protein in people who have Parkinson's disease or dementia with Lewy bodies. And there's really two platforms that are out there right now. One is a set called the alpha-synuclein seed amplification assay. This is a test that has been very well validated based off of spinal taps anyway. It is commercially available and can be ordered by physicians right now, but of course it requires a spinal tap anyway to be done anyway, which generally is very safe and usually goes quite well, but understandably not everybody wants to get one of those. The other platform that's out there is a skin biopsy, where basically what they're doing is taking a 3mm set of 3mm punch biopsies from the shoulder, knee, and above the ankle, and then looking under the microscope to see if they can see little alpha-synuclein aggregates that are in the small nerve fibers that go to our skin. This is also commercially available right now and can be ordered by physicians. If we're going to compare and contrast, I guess, obviously the skin biopsy, most people view that as less invasive, but there's been a whole lot more published using the spinal fluid test than there has been using the skin biopsy test. However, both seem to work pretty well in dementia with Lewy bodies anyway. But we can maybe talk more about that in the Q&A if people are interested. But these are exciting new tools that are going to help us be more diagnostically certain for folk when we're trying to figure out what they have. I'm going to switch over to treatment issues anyway, and treatment is really kind of tailor-made for people as much as we can based on the symptoms that they're dealing with. For the memory impairment things, donepezil, also known as Aricept, and rivastigmine, also known as Exelon. There's pretty good evidence that it helps cognition in dementia with Lewy bodies and Parkinson's disease dementia issues anyway. And sometimes that causes a bit of stomach upset. Some people have very vivid dreams with these, so not everybody can tolerate them. Memantine, also known as Namenda, it hasn't been studied that well in DLB anyway, so sometimes we might try it anyway, but the evidence is frankly fairly scarce. As far as the visual hallucinations and delusions and paranoia, sometimes these memory drugs are actually a little bit helpful for the visual hallucinations. I tend to find them to be fairly mildly helpful overall. But honestly, we're usually leaning a bit more on the lower bullet point there, using low-dose Seroquel, quetiapine, pimavanserin, also known as Nuplazid, was really approved initially for Parkinson's disease dementia, and they're getting approvals pretty soon, probably for DLB as well. There's an older medication called clozapine, which is fairly effective in dealing with visual hallucinations in Parkinson's disease dementia, and likely would be helpful in dementia with Lewy bodies as well. But the issue with clozapine is that it requires extremely, extremely frequent blood draws to monitor for a very rare but very serious and sometimes fatal side effect of the medication, where people's white blood cell counts drop to 0. And blessedly, that's not very common, but still it limits our use of the medication because of that danger anyway. If people have a significant amount of Parkinsonism, you can consider using carbidopa-levodopa to try to treat that in people with dementia with Lewy bodies anyway. You have to be kind of gentle and slow with it, though. Mostly because sometimes you can actually worsen the visual hallucinations and sometimes the paranoia with dopamine-type medications anyway. So I tend to start very low doses anyway for people who really need it, and really tell people, hey, keep an eye out if anything is getting worse while we're doing this. We try to avoid anticholinergic type medicines because it can make the memory and thinking worse. For some people who have a lot of problems with their acting out of the dreams, when, spouses are getting punched or hit, or people are falling out of bed even, pharmacologically, you can try to treat this with melatonin, just regular over-the-counter melatonin. Most adults would start with 5 milligrams. You can go up a bit higher anyway. But if that doesn't work or isn't enough, basically, Klonopin has some good evidence that it helps with this. As Dr. Longardner talked in much greater detail than I will, some people with DLB and PDD will have some orthostatic hypotension, drops in blood pressure when they stand up, and increasing fluid and salt intake. Compression devices can be helpful, as are these pharmacologic agents to gently raise the blood pressure, hopefully not too high. Fatigue and somnolence is really hard to treat in DLB and PDD. There are just frank neurochemical structural changes that are happening to the sleep centers of the brain anyway. Sometimes just really amping up caffeine intake can help fight this a little bit anyway. We tend not to use a lot of stimulants in this setting anyway. Like other pharmacological stimulants, I mean, like Adderall or Ritalin. It seems to be too much and actually might be harmful for the brain in this setting. For gait instability and falls, physical therapy is still a mainstay for this, and people often will need to use other assistive devices like a walker to help them. And sometimes an occupational therapist can come to the house to do actually a home safety assessment. Usually they'll recommend installing grab bars in the showers, bench in the shower, taking up throw rugs, so that people don't have a less likelihood of tripping or falling anyway. As for problems with chewing and swallowing, speech therapy sometimes is recommended anyway as well. And sometimes they'll actually ask people to modify what types of things they're eating or how they're eating it anyway. Sometimes chopping up things very fine or using thickened liquids is necessary to make sure that we don't get aspiration pneumonias. Drooling is a big issue for some people. We tend to lean on botulinum toxin injections to the big glands in the cheeks anyway. These usually are very effective, but do require injections every 3 months or so. For people who have significant anxiety or depression, traditional antidepressive medications like SSRIs tend to be helpful. And then advanced care planning in general, I always try to encourage people to talk to their families, especially when they're early on in the condition anyway, to talk about what they really want out of their medical care. These are harder conversations to have as the disease progresses anyway. And for people who are reaching more advanced stages of the disease, certainly, and sometimes even earlier can help too, getting engaged with palliative care can be helpful for symptom management and navigating advanced care options. It's always a good idea to try to touch base with an elder law attorney at some point as well anyway, just to make sure that assets are properly being managed anyway, just because as people advance in the cognitive changes anyway, oftentimes other family members, spouses, or children will take up the responsibility of managing those things for people as well. And this is a specific type of law attorney anyway who can help navigate those issues. There are some national and local resources that can help for people who have DLB and to a certain extent PDD as well. The Lewy Body Disease Association, or Lewy Body Dementia Association, sorry, is one of the better national and international foundations that provides a lot of help and sponsors some of the patient engagement activities that we do in the county. And the Parkinson's Disease Association of San Diego is a more local one that is pretty well established throughout the county anyway, and does have some offerings for both PD dementia and dementia with Lewy bodies as well. As far as research opportunities, at its core, all research is optional. We always start with that. We have been a site for the Dementia with Lewy Bodies Consortium study, which is a study where we are evaluating people who have either dementia with Lewy bodies or Parkinson's disease with significant cognitive impairment, and doing assessments basically on a yearly basis. And some of those assessments do include blood donations, cognitive testing, some imaging work anyway, and spinal fluid donation as well. UCSD has a longer history in the Alzheimer's Disease Research Center, the ADRC, but truthfully, the ADRC takes care of other people too who don't have Alzheimer's, who have DLB. So people can participate in that longitudinal study, and they have an option for brain donation through that for anybody who is interested. We are still running various biomarker studies to help support the development of faster, more accurate, and less invasive ways to figure out what people have. Mostly this is resulting in people with DLB donating small skin biopsies and blood samples anyway. And there are some medication trials that are ongoing anyway. The Rewind trial in DLB, which is looking at this medication, neflamim, never could say this one anyway, but that one has wrapped up enrollment, and they are getting close to being about a year into that one. So hopefully we'll start seeing data pretty soon out of that. There are some ongoing NIH initiatives, actually an open call to assess anti-amyloid therapies in people who have DLB and evidence of concomitant Alzheimer's pathology anyway. So keeping an eye on some of those things too. But that is all I have for you guys at the moment. I am happy to try to take questions on this.
Okay, great. Thank you. So if you have any questions, please type them in the Q&A box. We've got a couple here. The first are slides shared after the webinar. We do recordings. Are you open to sharing slides, Dr. Coughlin?
Yeah.
Okay, I can send an email out, and for those interested, we can share. Okay, next question. Is the main difference between DLB and MSA where the inclusion bodies deposit? Is there a lot of overlap?
This is a great question. So there is a fair amount of clinical overlap. You heard us talk about a lot of similar clinical features anyway. Pathologically, they are both marked by alpha-synuclein pathology, but the types of cells and brain areas that get affected are different. So with Lewy body diseases like Parkinson's and DLB, the synuclein largely affects neurons and in fairly proscripted areas of the brain. Whereas in MSA, multiple systems atrophy, the synuclein actually affects the white matter the most, specifically oligodendroglial cells. They're really the main ones. They're much smaller cells. And why this happens is not really clear to us yet anyway, but they're very distinct from each other pathologically, even though the person in the office may have a lot of similar symptoms. If you really want to get into it, like if you use electron microscopy work anyway, like the way that the synuclein misfolds is a little bit different between Parkinson's disease and DLB and multiple systems atrophy.
Okay, next question. What is your opinion on CBD and or medical marijuana, higher THC, to assist with depressive apathetic affect with Parkinson's and DLB with hallucinations?
It's a good question. I think it's understudied. I think that these have been studies that have been very difficult, if not impossible to do because of federal regulations anyway. But some of that is changing anyway. I think that we have at least a reasonable expectation that CBD THC type preparations would be helpful for pain, anxiety, promoting sleep, and appetite anyway. And that is very useful in many contexts in neurologic diseases anyway. I think that what we don't know about right now is how CBD and THC preparations may affect directly some of the disease features of PD and DLB anyway. And I would exercise a little bit of caution with some of that anyway, for a couple of reasons. One is that at its core, THC and CBD, as delivered from dispensaries, is not regulated in the same way that pharmaceutical medications are, which means there's always variability in what you're getting and how strong it might be, despite the milligrams that might be recorded on a package or something. THC could potentially make cognitive impairment or hallucinations or paranoia potentially worse anyway. So I'd be careful about that, or at least, just be prepared if something flares up a little bit. And with CBD preparations, one thing to keep an eye on with CBD is if people take a fair amount of CBD, it actually changes how the liver handles other drugs as well. And frankly, the drug levels in people's blood for other things can go quite high anyway. This is experience that at least I personally am drawing on from my old residency days when In the children's hospital, they were using CBD from four kids who had a fairly severe form of epilepsy. And you really had to watch those kids because their other epilepsy drug levels would go very high when they started their CBD preparations. And then we had to cut their doses back a lot anyway. So yes, I think that there's still a lot of interest, but I'd love to see some more data so we can kind of say like which symptoms it's going to work on and what the pitfalls might be that we get to talk to people about when we start using this type of stuff anyway.
Right. Okay, next question. Any updates on life expectancy of Parkinson's with DLB?
Life expectancy. These numbers are very different from person to person in a nutshell. It makes it really hard for us to sensibly prognosticate or tell people what we expect is going to happen anyway. I mean, if you look at most of the stuff that's published anyway, with DLB, people might quote an average survival of around somewhere between 5 and 10 years anyway, I would say. But around that average is a lot of people on either end. Some people who might have the condition and actually do pretty well for like 15 years anyway. And then there are some people who get worse a lot faster also. It's one of the things that we're not terribly good at yet. It's one of the things that's a fairly intense focus of a lot of the ongoing research is what are the factors that make people do well and get into that 15-year, like I'm doing pretty well kind of group, and what are the factors that maybe make things progress faster.
Okay, next question. Does the misfolding of alpha-synuclein relate to genetic mutation?
Also a very good question anyway. So only in a small number of cases, I would say. Now, when you talk about genetics, I got to divide up Parkinson's and DLB a little bit. So the vast majority of dementia with Lewy bodies is not genetic. It's pretty rare for it to run in families. It's not impossible, but it's very, very rare. Parkinson's disease is a little bit different anyway, where still the vast majority is not genetic anyway, but probably about 12-ish% of people who have Parkinson's will harbor single genes that cause the condition anyway. The vast majority of these will still result in alpha-synuclein pathology anyway, but the reasons for it are a little bit different anyway. Some of the genetic mutations that are out there either have to do with the synuclein protein itself anyway, and having a little bit of variance in how the protein is produced, making it a little more likely to misfold. But probably the more common mutations just have to do with how the body handles the protein. Like normally when we create proteins in our cells, they do their job for a while and then the cell basically gets rid of it. It chews it up in these little garbage pits that we call lysosomes anyway. And in some of the more common mutations that are out there, it's actually these garbage dumps that don't work as well. So the garbage kind of piles up, to be honest, and then that promotes the aggregation and everything. So in a sense, yes, but still the genetic changes probably account for a fairly small minority overall.
Okay, I think this might be our last question, but what are your thoughts about these diseases being caused by autoimmune issues? For example, the proteins being misfolded due to an autoimmune activation.
That's also a good question. So I think that these are I have to like couch this a little bit anyway. So they're not probably autoimmune in the sense that like lupus is an autoimmune condition or paraneoplastic syndromes are autoimmune conditions. But that being said, there are alterations in the immune system that either seem to promote this happening, and there's certainly a fair amount of inflammation that accompanies the pathologic changes with PD and DLB anyway. In fact, that Rewind DLB study, the neflamimab medication was actually a very potent anti-inflammatory medicine. And when we talk about inflammation, that is at its core the immune system trying to clean up stuff, and sometimes it goes a little bit too far. So inflammation, and in that sense, immunity does probably play a role, but it might be a little bit different than what we would traditionally think of as like an autoimmune disease. But I will say that inflammation in general gets a lot of attention anyway, and a handful of things that, yes, that are going through trials right now are really specifically targeting the inflammation aspect of things. We're actually a lot better as a medical community of working on inflammation than we are at some other things. So,
All right, and last call for questions. We can see how fast people can type. Okay, I think we're going to wrap up for today. Thank you, Dr. Coughlin, for your presentation. Well, I think we might have one more question.
excuse me.
The best place to donate to your brain.
Great. So this topic is near and dear to my heart anyway, because I do help run the neuropathology core here anyway. The best, if you're in San Diego anyway, it would be the best to try to get enrolled in one of these studies, either the Shiley Marcos ADRC, the Alzheimer's Disease Research Center, or the Dementia with Lewy Bodies Consortium, because both of those studies help support brain donation initiatives anyway. I do think that people really should get involved with one of those studies beforehand, mostly because while a brain donation itself is extremely valuable, it is like exponentially more useful if we know other things about the person who is doing the donation anyway, about how long you had the disease, what types of problems you've been facing, and ideally collecting a few other samples like a blood sample or a skin test or an MRI or something, because then you can really ask the really important questions about how some of these biomarkers fit together. And both of those studies facilitate that. If we're not in the San Diego area, the NIH has a sort of nationwide brain bank program as well. And then I guess, does Cure PSP still support this type of thing too? Lisa, you would know actually.
Yes, and actually one of our attendees reminded us too that the Brain Support Network is a nonprofit in Northern California, and they help get people connected to different programs like the Cure PSP out of Mayo Clinic in Florida.
Yeah, so there's a number of different ways to do it. If you're local, we have a number of local things, but yes, there's a number of national organizations like Cure PSP and the NIH that help facilitate this as well.
All right, I think we're all set for today. Thanks again for everyone attending and your presentation. I will get the recordings out hopefully in the next week or so and send a follow-up email to everybody. After you close out your screen, there will be some questions, a post-session survey for you to answer. So thanks, and we'll see you next time. Bye, have a good weekend.